afternoon, everyone. Again, very glad to meet all of you and to discuss something very vital. So I know it's fun. So the vital signs are called because they're very vital. And as Dr. Nitya pointed out, we consider it basic. It's a very basic skill everybody should know or must know. So that is the reason we don't really talk about vital signs. Now we just mention it and then go to other training. Even we know we are doing that. And if you go to any hospital and in the list of courses we say we also do vital signs, most of them don't opt for it because they think it's very basic. So I wanted to uh, uh, do this program so that do the small webinar to highlight the errors which can happen in the measuring vital signs. I'm not going to talk about how to measure vital signs. I think it will be insulting you if I do that. So I'm only going to talk about while measuring, what are the problems which can happen or errors which we might do and how to avoid them. So this is what no, I'm going to talk now. And so let me go to the next or the first slide. So today's agenda is what are the errors and why we have to talk about it, their importance. And I'm going to talk about the traditional vital signs, pulse rate, temperature, respiration, BP, and oxygen saturation now also has become one of the core vital signs which all of us do. In addition, I'm also going to talk about pain measurement and CBG measurement, which I think most of the time the vitals measurement also includes this. So pain, in fact, is called the fifth vital sign, isn't it? So I'm going to talk about the errors which can happen while doing these sort of measurements also. So we're going to talk today about errors in vital signs measurement. So vital signs, as you all know, are the pulse, temperature, respiration, and blood pressure. These, as I said, are the traditional vital signs. But we also have oxygen saturation, and assessment of pain and the capillary blood glucose. We also will deal in this webinar. So what are the most common errors that happen during vital signs measurement? One is not recording or documenting. Now, missing to do vital sign is, of course, a very common error. Not done on time is again another error. Transcription. See, most of the time now we're using electronic um, gadgets, or you might note it on a piece of paper as you go around, and then you have to transcribe it into the case sheet of the patient. So a lot of times when you copy from the piece of paper where you have entered, transcription errors happen. So that is another common error. And there is one called the digit preference. So even though it's an odd number or in between, we always round it off to the nearest 5 or 10. You would have noticed even the polls I do that. No, it's 43% was there. I would have said 45%. So we have a tendency, a preference to the digits 5 and 0. It's from our schooling. We've been trained like that. So that is another error which can happen while we are, when accurate measurements are necessary. That is also an error actually. And the last one is something which we don't want to talk about, is not measuring but recording values for normal patients. So I'm not using any strong words like false or lies and things like that, but I'm just telling very nicely, not measuring but recording values for normal patients. We don't actually do it for patients who are sick, but normal patients, we know, okay, the vitals are normal. Let's just write down the normal values. So why is so important to know about these errors? No, because errors will cause misdiagnosis and delayed diagnosis, which is we don't want to have that. Inappropriate treatment decisions because of the values are different, especially BP. You may brand somebody as hypertensive and start them on treatment or not start treatment at all. So inappropriate treatment decisions is another aspect why it's important not to make errors. Failure to recognize deterioration, especially in a patient who suddenly turns around and you don't document it properly. Errors and triage decisions, especially in emergency, that can happen. And when you go back retrospectively and want to do some research, And if your data entry is not correct, then obviously you will come to the wrong conclusions when you do the research. So these are all the important reasons why we should talk about errors in vital signs. And how often does it occur? I mean, I searched through the literature. There are variable, new literature which says, different values. Most are retrospective. They look at the charts over time, and so it is very difficult to actually prove that what the percentage of errors are. But so the range is very wide. So some hospitals say 3%, some hospitals even say for one particular aspect of vital signs it's almost 60%, especially the blood pressure. And so these are some of the references I looked at. So it's very variable, and it can be up to 60%. That's something which you have to keep in mind. So digit preference, I already mentioned. It is the tendency for healthcare providers to record measurements that end in certain digits, most commonly 0 or 5. Some people may have a digit preference, they may lucky number may be 8 or something. So they keep rounding out to that. So the digit preference is one cause of error. So for example, once 18/78 was the actual reading, but it'll be rounded off to 128. You do it all the time. And for example, half degree, 37.5, instead of saying 37.3, or if it is 37.1, we'll say 37. Now we'll just round it off to the nearest 0 or 5. Does it really matter? You may ask. One is, if you're really wanting to provide quality, then it is not accurate. We want to provide the highest quality, then you are not actually noting down the accurate measurement. So people might criticize you for that. And it makes a difference definitely in ill patients. So that is why the digit preference is being talked about. So let's go one by one, and I'll point out the errors which can happen and how to avoid it. So the first is the pulse rate measurement or heart rate measurement. So what are the errors which can happen? You could measure the pulse by using the thumb of your finger and not counting it for 1 full minute. What is the problem in measuring it with the thumb? Because the thumb itself has got a very prominent pulse. And you may actually be feeling your own pulse, when you feel with one finger. So that is the reason we ask, to measure with 3 fingers, so that, it is sort of spread over the 3 fingers, and this confusion of feeling your own pulse will not take place. So use 3 fingers and not counting for 1 full minute. Okay, you can once you see the patient for the first time, at least you should measure for 1 full minute. Why should you do that? Mainly to look at rhythm abnormalities and some missed beats. So you can detect this only if you do it for 1 full minute. Once you know that the patient is normal and it is a couple of times you measure, then maybe you can just do it for 15 minutes or 30 seconds and multiply it and put the heart rate or pulse rate. So now, most of the time nowadays, we don't actually feel the pulse, which is actually very sad. The pulse, feeling the pulse actually gives that touch, the healing touch which the patients expect us to have. So it has become very impersonal now with just put those pulse oximeter probes. I'm sure some innovative person may come with various shaped in pulse oximeter probes to give the patient more comfort, like teddy bear and things like that. But for now, what are the problems with pulse oximetry which may have? One is the improper placement. If you don't place it properly, the sensor should be exactly on the nail bed. So it's very important. So if you are not placed it properly, then you can get a false reading. Then improper values due to low perfusion. You see that all the time. Patient who are in shock, or when it is very cold, then the pulse oximeter will not read. Then you have to warm the extremities or put a blanket and then do the pulse oximetry. Not reading due to nail polish or artificial nails is a common problem. So you have to make sure that they are removed. And finally, ambient light. If you have too much of light, ambient light on the pulse oximeter, again, it will not read. So you have to make sure you don't have any direct light over the pulse oximeter while you are reading them. So these are small precautions you have to take while measuring the pulse rate using the pulse oximeter. So let's go. So that's about pulse. So pulse is, don't use just the thumb, use the 3 fingers. Count for full minute to detect any arrhythmias. If you're doing with a pulse oximeter, make sure you know about the equipment problems which can creep in and avoid them. So that's about the pulse rate measurement. Next, let us go into temperature measurement. So choosing the wrong method. So, it can be oral, rectal, tympanic, axillary, or temporal artery. Any of these are, can be used for temperature measurement, but when to use is very important. And also improper placement of the thermometer, especially, if you're placing in the axilla or even the oral cavity. If you don't place them properly, errors creep in. So rectal method is supposed to be the gold standard because it is very close to the core body temperature, but unfortunately, it is not always practical to stick a thermometer into the anus every time for a patient. So that's the reason we use oral, which is the next best method. Forehead and axillary are actually only screening methods. No, we actually do it for children and put the, add that whatever value to the axillary temperature. But if you really look at the science of measuring temperature, you got to measure the core temperature. So the rectal and oral are the most appropriate. Of course, for infants, you use even the forehead temperature and or the temporal artery temperature. But for most of the time, you will be using an oral method, and that's fair enough. Another important thing is make sure that eating, drinking, smoking, or physical activity is not done before taking a oral temperature. It can alter results. So if you should ask the patient if they had a hot drink or something. If they have done, it's better to wait for 15 to 30 minutes before such activities, before measuring, and making sure such activities do not happen. Ignoring the impact of circadian rhythms is very common, especially, people will say that you got a temperature in the evening. Actually, it's part of your circadian rhythm where the temperature is low in the mornings and then it goes up in the evenings and then comes down in the night. So be aware of that. And also note the time of the day when measuring so that while interpreting, you can say, okay, this is in the evening and maybe it is not that significant. So that's about temperature, not much. So basically, it is you choosing the right method and also being aware of the activities and the drinks which patient can take, hot drinks especially or cold drinks, which can affect the accuracy of reading, and also noting the circadian rhythm of the patient. Let's go to respiratory rate next. First, I want to face the elephant in the room, as they say, making up values. Okay, not measuring but writing down the values is a very common practice in respiratory rate documentation, not only in India, all around the world. No, this is a common problem. So if you can see, all the other measurements are measured. Respiratory rate, because just like that, you'll put 16 or 18, but you don't want to talk about it. So very common respiratory rate, and gradually it becomes a habit to the extent when actually a patient becomes sick and tachypnic. This has happened several times, in my own experience. I would look at the patient and know that the patient is having increased respiratory and tachypnic. I look at the chart and it'll be written 16, 18, like that in the last few hours. That is because of this habit that we just sort of take this respiratory rate for granted and write down these values. So it's something which you have to become aware about and make sure that you're always looking at the to see whether the patient is abnormal, and then make sure you write the correct values. The second thing which can happen is while measuring the respiratory rate, making known to the patient you are measuring the respiratory rate. So this usually, in experience. So patient is aware, then they become conscious and the respiratory rate will vary. So the usual trick is do the respiratory rate measurement soon after pulse. You keep the, your finger on the pulse so that the patient thinks that you're still measuring the pulse, but then you measure the respiratory rate, looking at the chest movement of the patient. So that is, avoiding awareness of the patient. So next is ignoring the depth of respiration. Now, just by observing the breaths rather than chest movements is a usual fallacy, because you will miss shallow respirations, which is early sign of respiratory distress. They won't take this usual normal breaths. No, they will be taking shallow breaths, which is frequent. So that should alert you. So it is not only just measuring the respiratory rate. Respiratory rate is also observing the chest movement and also looking at the depth of respiration. And if you find any problems, then go and measure it accurately and note it down. So this is something which you have to practice. So that ends the respiratory rate. And as I said, respiratory rate, most important problem is not measuring it but recording it. Then making sure the patient is not aware that you're measuring the respiratory rate, and focus on the depth of respiration and looking at the chest rather than just counting the breaths. Now let us go to the blood pressure measurement. This is where most of you said it was challenging. And as I said, a major part of my talk is about this. So the most common error which happens is choosing the incorrect cuff size. A cuff, either it is too small or too large, will lead to inaccurate readings. And you have to choose the correct cuff size so that it's fits properly. We will look at how to choose it. But I wanted to point out there are several other things which affects the blood pressure measurement, like talking and active listening. Not only talking, but if you talk to the patient and know about an important problem and they're actively listening, then also the blood pressure variation can happen up to 10 mercury. Distended bladder 10 to 15, cuff over clothing. They say, it's okay. Just if it's a long sleeve, just put the cuff over the clothing. Many of the, sometimes I've seen these instructions being given, but that can have a variation of between 5 to 50 mm of mercury. So better to put the cuff on a bare arm. Very, very important. Smoking within 30 minutes of measurement, 6 to 20. Back, sorry, back unsupported, 6 to 10. Legs crossed, 2 to 8. Arm unsupported, 1 to 11. So make sure that all these things are taken care of. So how do you select the correct cuff size? One is, traditionally we are taught in the nursing school or medical school that you have to use a measuring tape and measure the arm circumference, the mid-arm circumference, and then choose the cuff size. It should be 80% of the arm circumference, 40%, that is the length of the bladder of the cuff should be 80% of the arm circumference, and the width should be 40% of the arm circumference. Length width ratio is 2:1. And you have to tie the cuff so that the bladder is over the center of the brachial artery. This is what is a pure textbook teaching. But how many of us practice it? Is it practical to carry a tape in your pocket to measure it for each and every patient, and then take a calculator out and calculate 80%, 40%, and then choose the cuff size? It's actually very impractical. Of course, you should tie the bladder over the center of the brachial artery. I mean, the center of the bladder should be over the brachial artery. That's important. But it theoretically sound, but practically very difficult to implement. So the other way is to just have a table. Make a table, stick it onto the trolley, where the vital measurements trolley, and say, if the arm circumference is so much, then this is a small adult. It's like a clothing size. Then use this cuff. But still, you have to measure the arm circumference. At least the calculation part is taken care of here. So now I'm going to tell a method which is more practical, how to visually choose the correct cuff size. This is how we do it all the time. But do you have a methodology? So this is a methodology, 3 steps you have to follow. One is you place the cuff, vertically over the arm. And then as the cuff folds over the arm, you must that fold should cover 40% of the arm circumference. Are you getting it? So you put it lengthways, and when you fold the cuff over, this the lengthwise fold should cover up to half of the arm circumference. 40% is almost up to half of the arm circumference. That is step 1, which is easy to do. It will take a few seconds, right? Step 2 is now hold the cuff like you usually do and just wrap it around the arm. The bladder should cover almost the full circumference of the arm, 80 to 100%. The bladder should cover. So that is the second step. Okay, the first is the length. You fold it over the arm. That fold, the lengthwise fold should cover. It will go almost half of the arm circumference. Then horizontally, you go around almost. It should the whole circumference should be encircled by the bladder of the cuff. The third is when you turn. Now the cuff should occupy 3/4 of the length between the acromion to the olecranon. So the cuff should be almost 3/4 covered. It should not be too small or too large. Okay, this is the ideal. This is too short, and this is too long, too wide. Okay, so 3 simple steps. Okay, put it lengthwise, fold it, and the fold should go just about half the arm circumference. Then put it horizontally and make sure the bladder is almost there, covering the full circumference. And then make sure that 3/4 of the arm is covered by the cuff, not less, not more. If you do these 3 steps, you chosen the correct cuff size. So it's a very practical method and you can use it every day. So only if you have selected the correct cuff size, only if all 3 steps are satisfied. Don't just do one. All 3 should be in. That's why it is lengthwise, it is horizontal, and then how much of the area it is occupying. All 3 are important. So the other things we already looked at: inappropriate arm position, arm being either too high or too low to the heart level. So keep a pillow or make sure that the arm is at the level of the heart. And the next is talking or movement during measurement. Don't talk. And tie the cuff on a bare arm. Back should be supported. See, most of the time you actually will ask the patient to swing the legs on the bed and take. That means the back is not supported, right? So just be aware of that next time you go, that the back is supported as well. Feet flat on the floor. It looks like a tongue twister, right? Feet flat on the floor, but not crossed. Okay, that's very important. So patient talking, moving, crossing legs can lead to false readings. So relaxed, sitting comfortably, and being silent during the measurement. And another important thing is not resting. No, patient will just completed his jog and then he'll take his measurement. So you have to be very, educate the patient also. Physical exertion should not be there and that will affect the results. So at least 5 minutes they should rest before you can take the measurement. And also using a poorly calibrated or damaged. So especially the mercury sphygmometer those days, when we use it, that rubber will be almost melted. The whole thing will be rusted, but still we'll be using it. I don't know how many years back it was calibrated, but that is how we used to measure blood pressure. At least now we have electronic things, but these electronic equipment should also be calibrated. Luckily, the manufacturers do keep updating this firmware and keep auto-calibrating it, but make sure this update is happening on a regular basis. It is the responsibility of the biomedical department to make sure that they are calibrated according to the manufacturer's guidelines. So fail to take multiple readings is another common error. So mostly the first reading will be a bit high. So you need to give a minute and then take the second reading, and probably if it is the first time, even take 3 readings and take the average. So very important not to rely on a single reading. This can lead to misdiagnosis. Take multiple readings and take the average or the most accurate assessment. Inform the patient how to do the measurement. I know the cardiologist whom I visit gives an A4-page instruction to each and every patient who's hypertensive, giving clear instructions how to take the blood pressure measurement. So such detailed education should be given. And not comparing both arms is a problem, because some people have blood pressure elevated on one arm than the other, and coarctation of aorta can be another where it is very, variation is very wide. So you have to take the blood pressure on both arms, make sure, and then decide on which arm you're going to take the measurement. Usually, cardiologists say that you should take the measurement on the arm which has got the lower blood pressure between the 2 arms. So that's about BP. Now we covered quite a lot, very important. And now we'll come to pain assessment. So pain assessment is, as I told, is a 5th vital sign, but most of the time pain assessment is done, but the full cycle is not completed, mostly because doctors, again, we are going to the doctors, that cycle has to be done. But sometimes errors in measurement also happen. So let's look at what are those things. One is bias and misconceptions about pain. Many times they will say, if you have an operation, you will have pain. So bear with it. That sort of thing. So these are personal biases, a misconception. And some people will say, when somebody comes with abdomen pain, don't give painkillers because the assessment will not be correct. All this is not true. The patient is coming to the hospital for pain relief, and as carers and as doctors and nurses, it is our responsibility to relieve that symptom first. That's very, very important. In fact, several studies have shown, especially with abdomen pain, because I deal with it day in and day out, giving analgesia actually increases the accuracy of diagnosis. So such personal biases should not be there. So you approach the patient with an open mind without judgment, not using standardized pain scale. Just say mild pain, moderate pain, severe. What is mild for you may be moderate for me and severe for another. So you should use standardized scales like numeric rating scale, visual analog scale, or the faces pain scale. Wong Baker's faces pain rating scale has become very popular now. So consistently using such a standardized pain assessment tools will lead to appropriate pain assessment and management. And we should also easy to communicate with others. When you're handing over and all that, it's very easy to communicate. Underestimating the pain in certain populations, especially, elderly, they say, oh, they don't feel much pain. Or somebody, especially mental health the patients, we really don't know. And we'll tend to assume that, they have some about the pain. Either they bear pain to a lot or they don't bear pain. It is all a bias. So you don't have these sort of prejudices about several populations. And now you need to look at both verbal cues, how they are talking when they're having the pain, how their behavior is there. That may be a clue to the pain rather than actually voicing the pain or assessing pain. And another thing I wanted to point out, which again in our training comes up again and again, is errors using the faces pain scale. So the faces pain scale has got these faces ranging from crying face on one end to the laughing face on the other end. And many times when I now ask, how are you doing assessment of this pain? They will say, I will look at the scale and then look at the patient, and which face matches I will put the thing. That's completely, not true, because the faces pain scale is there only to give the patient an idea of how severe is the pain. It is not to compare that face with the patient scale. It's misunderstood. And again, this misunderstanding is not there only in our country, because there are references where this misunderstanding is there all over the world. So this is a very common misunderstanding in the faces pain scale. So comparing the faces scale, that is the picture of the faces scale, to the facial expression of the patient is the error. So understanding that the scale is a visual guide, both for you and for the patient, then giving a proper explanation to the patient of how to use the scale. You should do that, spend that time. Tell this is the scale. It shows that, this side the patient is crying, this face is crying, this side the face is smiling. That means this side the pain is a lot, that side, no, there is very little pain. And they explain that. So I'll show you a small video how a nurse asks the child and how the child is able to accurately tell about it. It's very interesting. So let me just play the video. Let me make sure the volume is there.
Thank you, Angelica, for letting me listen to your heart and to your tummy. I know that you're in here because of your cough. Now, if your chest had a face on it, what would you say that your chest face would look like? Does it hurt? Would it have a happy face or a sad face? Okay, so you're not hurting anywhere on your chest? How about your tummy? How does your tummy feel? It feels happy? It feels good? Okay, thank you.
So you can see actually the faces pain scale was made for children because they're not able to express their pain properly. And you could see how nicely the child was able to point out looking at the faces. So this is what you should explain to the patient, saying that, explain to them clearly what they are supposed to do while using the scale. So that's what I wanted to tell about the faces pain scale. So let's go to capillary blood glucose measurement. And the first error is the improper site preparation. Either they are unclean and improperly prepared can cause errors. So I ask the patient to hand wash if their hand is soiled, or clean the site with an alcohol swab. Let it completely dry before doing the pricking with the lancet. So that is about improper site preparation. Then using the first drop of blood is an error, because the first drop of blood can have more of interstitial fluid and it's diluted. So it may affect the accuracy and actually may show a lower blood sugar value. So you should always wipe off the first drop of blood and then use the second drop for testing. The third is squeezing the finger too hard. Again, will lead to more of interstitial fluid coming and diluting the blood. Therefore, gently massage the finger without squeezing excessively if you want to get the blood out. So that's the third point in about capillary blood glucose. Not changing the lancets regularly can cause pain, infection, inaccurate results. So make sure a new lancet is used, to ensure sterility and accuracy. And just like the pulse oximeter, any equipment, you need to make sure that it is working properly, it is fully calibrated. So that's important to monitor both the meter and the strip performance. Audits have to be done for both. So that brings us to the end of the errors which happen in all the vital signs, including pain and capillary blood glucose measurement. I want to end with pointing out that technology is now in place where you could do the measurements accurately and also get the values directly into the electronic medical record system. It's available as of today. It is not a future technology. It is available today. As you can see, you could just put those probes under the patient and use an interface. Either it is a phone-based interface or a tablet or whatever. Now it is the mobile, which is used most of the time. Then there is a wireless which will go to the cloud, and then those values are directly entered into your electronic medical records. Very, very, it's not very expensive. Now, it is expensive than just doing your own thing. But if you look at quality and reducing errors, definitely it'll pay the cost in a few years. So there are again other contactless remote monitoring systems available. Very, amazing. Initially, I was very skeptical about it. There is only a sensor underneath the patient's bed, and it grabs all the vital parameters of the patient using a quartz-based technology. And they have done several studies and proved that it is as accurate as a ICU monitor. So then you can see the nursing effort goes down a lot, and two, the error comes down also quite drastically. So here is a hospital which did this study and of using electronic medical records and wirelessly transferring thing. Before they introduced this phase 2 is introduction of the technology. You could see systolic blood pressure, diastolic blood pressure, number of errors, error rate, especially heart rate. There were so many variations. And then temperature, no, there was not much. Oxygen, pulse oxygen, respiratory rate. So totally, there were about 72 errors and about 18%, nearly 1 out of 5 patients, there was error, which is completely eliminated using technology. Because this technology, there's no transcription error, no bias, whatever, and you only have to make sure those probes are done, in the proper place. And now with the contactless remote monitoring system, you only need to keep it under the bed. So think about it. It's something which I wanted to point out, that today technology is possible where I don't even need to have given this talk. I'm sure in another maybe 3 to 5 years time, my talk will become obsolete because everybody is using technology. Okay, so that's something to consider. So in summary, I wanted to point out that errors and discrepancy in vital signs occur quite frequently. They're unique to each vital sign. So you should know how to avoid each one of them while doing each and every vital sign. And being aware of the common errors will help in avoiding them. It raises the awareness. Oh, this many mistakes are happening. Therefore, I should be careful. And finally, as I pointed out, using technology as of today has the potential to eliminate these errors completely. So with that, we will come to the end of this presentation. Thank you so much for your attention.
Thank you so much. So we will end this program. Thank you so much.